All right, so is there any questions from last time we were covering? Either the muscular stuff, maybe control of the muscles, things like that? All right, because probably just putting that off until study time, and then the questions will come. That's okay. All right, so anyway, we're talking about neurotransmitters. And again, we'll go over some of the more common ones you're going to run into from a medical standpoint, especially because these are going to be things that we can modify to a pretty great extent, especially through medications and whatnot. So we're going to see. So again, this isn't really a pharm class, but I'll show you some examples of ways you can modify things to cause different physiologic effects to actually take place here. And again, a lot of these you're already kind of familiar with. Does anyone remember like beta endorphin, what that does? Or endorphin? Makes you happy. It's kind of like our natural sort of like opioids that we can release there. It's like, you have like a runner's high or something. I've never experienced that. I still think that's a myth, but they claim you release endorphins when you run long distances, and I say, no, that just sounds horrible. I just produce a lot of lactic acid, and then I cry because I'm in pain. Anywho, but you run across all these. Yes, ma'am. I am, but is the thing not working? Check, check. 1, 2. Is it not? Maybe the volume's down. Hello, hello. Is that better? Sibilance. Not at all. Let me try. Does that work? Yes. All right. Start my beatboxing. Which show? Oh, I said I don't believe in the runner's high. I believe that I just have a lot of pain associated with that, cramping, lactic acid production, and it's just no good. So, anywho, yes, but lots of neurotransmitters you're going to run into. Again, a lot of these are going to be hormones that you will we've already talked about. So again, I'm not going to go over every single one of these. But for instance, things like substance P. Anyone know what that does? Substance P. Does it make you urinate? No. It actually has to do with pain. So for instance, when you have things like capsaicin, anyone know what capsaicin is? Spice, yeah, it's what makes chilies and peppers and things like that spicy. Is going to be capsaicin. Actually stimulates substance P to actually cause pain, right? So again, if you're ever like cutting up a jalapeno and then you invariably like touch your eye, because of course that's the 1 second your eye waits to itch. And that's a lot of substance P, and actually can use that for pain control for certain conditions. But anyway, we'll talk about a lot of these later. But let's go into the main ones. Standpoint. Everyone's familiar with acetylcholine, I would imagine, right? I might have mentioned it once or twice. Again, this is made just from the combination of acetyl-CoA and then also choline there. The reason why it's important is because we want to make sure that we can form it, but also break it down into its byproducts, right? Because again, this is one of those things where you don't want to have too much acetylcholine around because that's going to cause some imbalances, as we'll see here in just a moment. Now, the enzyme that breaks down acetylcholine is acetylcholine esterase, right? So again, this is an enzyme that's going to be, it works very quickly to break down acetylcholine into its constituent components, and we can actually recycle the choline for later. So you actually will find that we'll be retaken back up into the presynaptic neuron, and they can combine with acetyl-CoA, and then can be utilized again. So you're going to see a lot of these efficiencies that are built into the neurons to try to make use of these neurotransmitters as much as they can, try to be efficient. And so we're going to find that acetylcholine is pretty ubiquitous amongst the transmission within the CNS. We're going to find it used in all sorts of different places here. So for instance, we are very familiar with it being used in which part of, like, say, the autonomic nervous system? Parasympathetic, right? So again, we've talked about that all semester long. However, did you know that it's also used in the sympathetic nervous system? So your mind's blown by that? I will tell you how, right? Again, we've already talked about pretty extensively its use in somatic control here, right? So again, you have these motor neurons are going to be releasing acetylcholine onto what types of receptors? Nicotinic receptors onto the muscle, and that was what's going to stimulate its contraction, right? It's going to open up those sodium channels, allow sodium to flow in, you have depolarization, etc., right? Looking at the autonomic case here, though, imagine you're looking at the parasympathetic nervous system. You'll have these neurons, and we'll have a whole section on this later on, but I just kind of want to mention it here. You'll have these neurons that will be releasing acetylcholine onto what sort of receptors? So you'd think muscarinic, but actually there's going to be these preganglionic sort of transmissions that have to happen here. So initially you're going to find that you're going to have, say, the cranial spinal nerves are going to be releasing acetylcholine onto nicotinic receptors on the ganglion, and then that will then in turn release acetylcholine onto muscarinic receptors on the actual cells, right? So again, you can find that there's going to be kind of preganglionic transmission and then this postganglionic transmission. This is what actually is causing the effect you're going to see. Anyone remember the mnemonic for parasympathetic effects? Yeah, dumbbells, right? So all the defecation, urination, etc., right? But again, acetylcholine there is used on the nicotinic receptor, and it's going to dump out onto a muscarinic receptor afterwards. Any question? Okay, perfect. So let's also look at the sympathetic. Actually, the same thing sort of happens here, where you can see that with looking in, again, we'll look at the innervation a little bit later on, but say you have these initial neurons from the sympathetic nervous system, they're going to be releasing acetylcholine onto nicotinic receptors on the ganglion, and then after that, it's going to release what? Norepinephrine, right? Because now we're talking about the sympathetic nervous system. So you'll see these are nicotinic receptors that acetylcholine is initially going to stimulate, and then it's going to release norepi onto what type of receptors? Adrenergic receptors, which fall into which categories? Alpha and beta, right? Those are the primary ones you're going to see there with the sympathetic nervous system. So those are kind of the main ways we're going to see communication with acetylcholine, both with somatic transmission and also for autonomic transmission. And again, it gets used in both sympathetic and parasympathetic. But again, you'll see acetylcholine being used both in both of the autonomic nervous systems based on the preganglionic usage, and then for the parasympathetic for the postganglionic usage as well. Yes, sir.
Yeah, for the parasympathetic, so is it ever directly release the acetylcholine on the muscle? Really good.
Usually it's going to go through the ganglion first with a nicotine. If there are, it's probably not very frequent, I would say. There's probably some rare instance where that occurs, but I'm not aware of it, as the case may be. So, yes, sir.
Can you just re-summarize the sympathetic one regarding like postganglionic and the receptors and the neurotransmitters?
Yeah, absolutely. And again, we'll talk about this when we get to norepi in just a few slides here. But looking at this, when you have the initial nerves that are going to be sending out that sympathetic transmission, right? So again, if the bear jumps out at you and scares you, you're going to find this is going to be releasing acetylcholine onto a nicotinic receptor on the ganglion. And then afterwards, you're going to see the ganglionic chains that occur with the sympathetic nervous system when we get into the last unit for this section. But then the ganglion is then going to transmit via norepinephrine releasing neurons onto the actual alpha and beta receptors there. Okay. Now again, there's some other kind of rare instances here where you can see that and again, where else do we get a lot of our sympathetic sort of hormones coming from? If not the nerves, then where else? Yeah, the adrenal gland, right? So the adrenal gland is going to release norepinephrine and more predominantly epinephrine. And so you can see here, this is actually going to be nicotinic innervation with acetylcholine as well. So again, you actually bypass the ganglion altogether, and here you'd actually have a direct innervation releasing epi and then norepi. But again, from the adrenal gland, it's going to be more predominantly epinephrine. From the sympathetic nerves, it's going to be more predominantly norepi. Okay. Almost like accidentally epi. So those are the kind of the main ways you're going to see acetylcholine being used both in the central nervous system for somatic transmission and also for the autonomic nervous systems. Okay, makes sense? Cool. Now, what would happen, say, for instance, if I had someone who had, say, a deficiency of acetylcholinesterase? What happened to my acetylcholine levels? It would increase. And what effects could I expect to see? Overstimulation of, say, for instance, we could see overstimulation of, say, the somatic nerves, right? So what happens if I have too much acetylcholine here with these somatic nerves? Yeah, so you can maybe have too much stimulation, right? So you can see initial activation of the muscle, but remember what we said about overstimulation of those receptors. What can happen? Yeah, they can become desensitized, and you can have paralysis that can occur there, right? So again, this is why initially we have a paralytic called succinylcholine. I mentioned they can actually activate those receptors, but then they desensitize. So they call that a depolarizing neuromuscular blocker, because it actually depolarizes the muscle initially, but then causes paralysis to occur. So you can imagine if I have someone who has, say, a deficiency of acetylcholinesterase, and they have too much acetylcholine, you could actually see paralysis. Now, what muscle, if you paralyze it, is probably most likely going to kill the patient? Yeah, so the heart's not going to be affected here, right? Because again, that's not really skeletal muscle, it's cardiac muscle, and it's going to work differently. However, the diaphragm is what's going to kill the patient. So if I have someone who had too little acetylcholinesterase, or if they had, say, a substance that was blocking acetylcholinesterase, causing there to be too much acetylcholine, that can actually lead to diaphragmatic failure. Not great, right? Because then the patient can't breathe. Okay, the intercostals and stuff would also be affected as well, but the diaphragm is kind of the big mover there. So that's one way you could have overstimulation with acetylcholine. That's just via these motor neurons. What would happen if I did the same thing for the parasympathetic nerves? If I had too little activity of acetylcholinesterase? Again, I would see overstimulation, and how would that manifest? So too much parasympathetic activation. We talked about our mnemonic, which was the dumbbells, right? So we're going to see D is defecation. Urination. Everyone with me? No. Meiosis. Good. Because the U is already urination, right? So bronchuria, bronchoconstriction, what does it do to the heart? Bradycardia, right? So again, we call this a killer beast because not only you're going to have the diaphragmatic failure if you had that deficiency, but then also your lungs are filling up with fluid, your heart rate's going to be going down. You can see how this can kind of spiral out of control if you had a problem with acetylcholinesterase. E, emesis, L, lacrimation, salivation. Perfect, right? So those are your dumbbells. That's going to be for your parasympathetic nervous system. So secretions coming out everywhere. So that could also affect potentially if I had too much acetylcholine and too little activity of acetylcholinesterase, what would happen with the sympathetic nervous system? That could also be overstimulated, right? Because again, you still have too much acetylcholine here activating these nicotinic receptors, and guess what? Now you're going to also have some sympathetic effects on top of that as well. Okay, so again, this can affect all of these if you had a deficiency of that enzyme, which is important because that can be a genetic thing, or there can be substances that can actually come about and do this, right? So certain pesticides we used to use more frequently here in the U.S. Can do this as well. It actually will inhibit that enzyme. So that's an important thing. So again, some of the questions I might ask on the test is, hey, if I decrease the activity of this enzyme, or say for instance I give the patient a whole lot of a substrate that turns into a neurotransmitter, what effects would you expect to see? And these are the things I want you to kind of have in the back of your mind. Okay, things you can kind of think through and reason out.
So if you had an issue with your acetylcholase and you're stimulating both the sympathetic and the parasympathetic at the same time, they kind of like negate out a little bit?
They don't necessarily cancel each other out. You just may see them kind of like stacking on top of each other. So in some cases they may be competing. So for instance, if you had stimulation of, say, the sympathetic nervous system on the heart, what would you expect to see? Well, sympathetic on the heart would be stimulatory. You expect to see tachycardia, right? But then if I have overstimulation of parasympathetic on the heart, what that should cause? Bradycardia, right? So again, depending, it can be actually pretty variable. And so clinically what we would see, so imagine, again, from a toxicology standpoint is where the scenario I would run into. So imagine there was a chemical attack, right? So again, someone released an organophosphate is something that blocks the activity of acetylcholinesterase. Initially, what you actually end up seeing is stimulation of the sympathetic nervous system. So you'd see these patients who are coming in, they'd be tachycardic, they'd probably be diaphoretic because they're sweating not only from the parasympathetic effects, but also from the sympathetic as well. And you say, okay, well, this looks like they're more sympathetic. Like, it doesn't really seem like it's one of these organophosphates. But then over time, they'll more manifest more of the parasympathetic effects, and their bradycardia will take place, or have that bronchuria, bronchoconstriction. So these patients can evolve depending on kind of what the situation is and what the actual exposure might have been, right? So that's where I see from a tox standpoint. Hopefully, we never see an attack like that, but it has happened in the past, right? So if you hear like VX gas or sarin or tabin, those are gases that actually do this, where they actually block acetylcholinesterase, right? And we've never seen the movie The Rock. Yeah, everyone should say yes. Of course, I've seen The Rock's one of Nicolas Cage's finest. They use VX nerve gas there, and I always thought it was the coolest thing, because when the guy like had the little green ball and it hit the ground and the gas came out, the guy's face like melted off, and I was like, that's so cool. I want to be a toxicologist. And then guess what I found out? It actually does not do that. Your face does not melt off with VX nerve gas. You probably like salivate and have tears and everything, but your face would stay on, as the case may be. So you should go watch that movie if you have a chance, if you are busy not studying. Just kidding. All right, next up, norepi. So we've been. Oh yes, ma'am.
So if you have a deficiency of acetylcholinesterase, are you going to ask it on a test like short-term deficiency versus long-term? Is it initially like you have like tetany and eventually?
No, I wouldn't get that. I would not get that granular with the question. We're not really at that level yet, I wouldn't say. So I would probably ask something like, which one of these effects would you expect to see from, say, the parasympathetic effects of having too little acetylcholinesterase activity, right? And so again, you'd expect to see bradycardia, you expect to see salivation, like, those sorts of things, right? So I'd be pretty clear on that. I don't want to trick you guys necessarily, right? Or intentionally, I don't want to trick you, but it can happen unintentionally. All right, so next up we have norepinephrine. So we talked about this being partially released from the adrenal gland, but also it's going to be a big neurotransmitter as part of the sympathetic nervous system. So this is actually made up from tyrosine in the diet. So where do we get tyrosine from? Our dietitian friend, do you know? Aged meats, cheeses, you can find it in red wine, things like that. So this is important because there's actually specific food-drug interactions you can run into, and I'll mention this in a second, but these are precursors you get from the diet that can eventually be turned into things like norepinephrine, right? So again, that's how we synthesize it from tyrosine in the diet. And then also we're going to see from the metabolism, there's two main enzymes that are responsible for metabolizing this. There's going to be this COMT, which stands for catecholamine O-methyltransferase. And anytime I say catecholamine, I'm usually talking about dopamine, norepinephrine, epinephrine. Those are catecholamines. Okay, it's just the kind of chemical classification they fall under. There's also one called monoamine oxidase. And this is actually how we used to treat depression for a long time, was using an enzyme or using a drug that would block the effects of monoamine oxidase. We'll see how that works in a second when we get to serotonin. But these two enzymes are responsible for breaking down norepinephrine. Okay. Again, I can ask you a question on a test. What would you expect to see if I gave a patient had a deficiency of monoamine oxidase? Which one of these effects would you see from norepinephrine? You could say things like, okay, well, I know that means if I have a deficiency in the enzyme, I'm going to have too much norepinephrine. I know that's going to lead to overstimulation of the sympathetic nervous system, and I expect to see, tachycardia. I expect to see miosis or mydriasis. Mydriasis, right? Because I'm overstimulating the sympathetic, right? I'd expect to see sweating, expect to see hyperthermia, things like that, right? So its main function, as I mentioned, is going to be with the sympathetic nervous system, generally going to be excitatory, right? So again, part of that fight or flight response. And then from the brainstem to the hypothalamus, we'll talk about this in the next section coming up a little bit later, increasing levels of wakefulness. So typically when you have norepinephrine coming in, you're going to be stimulated, you're going to be awake. This is one of the things that if you have a patient who has some dalliances in cocaine, it stimulates release of norepinephrine. Those patients, are they usually pretty sleepy or are they awake? Generally pretty awake. I don't know if you've ever seen someone on cocaine, but I've had the unfortunate pleasure of seeing plenty of them, and they are very, very awake. We'd rather them be a little bit sleepier, but quite awake. Usually yelling and fighting you and all kinds of stuff. Anyway, that's just my personal life. Right, so the main receptors you're going to see norepinephrine going to be interacting with is going to be the adrenergic receptors, right? It's going to be classified in your alpha 1 and 2, and then we're also going to have beta 1, 2, and 3. Remember, where do you predominantly find beta 1 receptors? On the heart, good. It usually is going to be stimulating contractility. It's going to be stimulating heart rate. Beta 2 receptors, where do I find those? Blood vessels are one place, yep. A lot of smooth muscle, right? So you can think about the bronchial smooth muscle. Think about the bladder. Think about all these different places where you're going to see different beta receptors. Typically, you're going to find a lot of this is going to be on smooth muscle, right? In some places, it's going to be contractile, right? So we mentioned. In some cases, we're actually going to see constriction of certain smooth muscle. In other cases, you're going to see relaxation. Typically, for beta 2, you're going to see relaxation of smooth muscle when you have activation with norepi, right? And again, there's going to be some bleed over where epinephrine, which we'll talk about in a second, can also interact with these same receptors, okay? You're going to find that with different neurotransmitters, they may have a little bit of preference of one receptor versus another, but in general, we kind of think of epi and norepi interacting with both alpha and beta receptors here, okay? Alpha 1, where do we find those most frequently? Not the heart. The blood vessels, yeah, those are the main ones that when we activate alpha 1, it usually causes what? Constriction. You should raise our blood pressure, right? Good. Yeah, so those are the main things you're going to find. We also find those receptors up centrally, and that's where we can see things like, that stimulation if you have, say, someone does cocaine or methamphetamines or something like that, increasing that norepinephrine release. This is why it's going to be stimulatory, usually acting on things like alpha receptors up in the CNS. Yes, sir?
Beta 1 leads to higher inotropy and chronotropy, right?
Mm-hmm. Okay. Yep. So beta 1 increases inotropy and chronotropy. Inotropy is just referring to what? Contractility, the squeeze of the ventricles, versus chronotropy is just the actual, the heart rate itself, the actual speed with which the heart is beating. Okay, good. Now remember, you're going to find that you'll have the normally what you're going to find, and you can see these pathways here, we're going to have things like tyrosine coming on, that you're going to have different enzymes are going to cause its actual production of the neurotransmitter. And again, I'm not going to ask you specifically like each step of the actual production of the actual neurotransmitters. However, like things like metabolizing enzymes, I would expect you to know, because we kind of mentioned it here. Now notice that there's precursors to norepinephrine. What do you see here? See dopamine. So dopamine is actually a common precursor to things like epinephrine and norepinephrine, which is why you see a lot of similar activities between the two. And you're going to see a lot of similar enzymes that are used to break that down. So that'll come back up in a second. But eventually dopamine gets converted over into norepinephrine. It'll be released from these vesicles to have a stimulatory effect. And again, one of the things you're going to see is that metabolism will occur here via COMT or monoamine oxidase. But how does how does this nerve know to stop releasing more neurotransmitters? How does it kind of get the signal, hey, I got enough neurotransmitter being released already?
when the receptors are full?
Well, so again, I could fill up the receptors here on this postsynaptic neuron here, but how does this presynaptic neuron know to stop releasing? Hmm?
You start producing enzymes?
Oh, this presynaptic receptor. Oh, good idea, huh? So this is another example of a negative feedback loop. So we actually have presynaptic receptors that are going to be located on this presynaptic neuron that when they get activated, it's going to say, hey, there must be enough here. If this is getting activated and shows I'm releasing enough of the neurotransmitter, it will then shut down further release. And so in this case here, alpha 2 is a presynaptic receptor that will actually shut down further release of norepinephrine. Okay, that can become important. We're talking about things like drugs like clonidine. Is an antihypertensive. It actually works by alpha 2, and so we things that decrease the activity of the sympathetic nervous system, we call those sympatholytics. And that is actually one way we can do that is by actually activating these presynaptic receptors can shut down further release of things like norepinephrine, right? So that's another way we can kind of modify the system a little bit by working these presynaptic receptors. Most of these neurons are going to have a presynaptic receptor. So again, you can find presynaptic acetylcholine receptors. You're going to find presynaptic norepi, dopamine, serotonin. These are all there because you need to have that negative feedback loop to occur to make sure you're not releasing too much.
Is that where the reuptake inhibitors act?
No, this is different. So we'll talk about reuptake inhibitors. So you can actually have transporters that will then reuptake certain neurotransmitters, and here it's less important for norepi. We'll talk about that with serotonin though. But yeah, so again, these presynaptic receptors just prevent further release of neurotransmitters because again, you don't want to necessarily have exocytosis of every single vesicle, then you run out. You won't have any left over. So you need to have that negative feedback loop there to make sure you're saving some of it, right? Okay, so next we have dopamine. I mentioned that dopamine, we talked about that yesterday. What kind of movement disorder can you see if you lose dopamine? Parkinson's, yeah. So you're going to find Parkinson's when you're losing those dopaminergic neurons, or the neurons that are releasing dopamine, you end up developing Parkinson's, right? So you have a hard time initiating certain movements as the disease progresses. And so dopamine itself is going to be made from tyrosine because we saw that it's actually a precursor to norepi, so that makes sense that it's also coming from tyrosine as well. And it will also be metabolized by the same enzymes. We have monoamine oxidase and this COMT as well, or catecholamine O-methyltransferase. These are both metabolizing enzymes here. What's actually kind of cool is if we have patients with Parkinson's, we know they're missing dopamine, so what would you think is the way to fix that disease? Give more dopamine. You have a question or you can answer?
Exogenous dopamine, but is the problem is like can't cross the blood-brain barrier, so
that is the problem. Yeah, absolutely. So you can say, well, let's give them more dopamine, right? But actually, what you find is that it can't cross the blood-brain barrier. It doesn't actually work that well. So what we actually can do is to provide a replacement, and we give something called levodopa and carbidopa. Levodopa is actually able to cross the blood-brain barrier, and then it eventually gets converted via these same enzymes over into, again, levodopa, L-dopa, that's basically the same thing here, it gets converted over to dopamine. That's one way to do it. What's another way? If I still have some dopamine around, well, what if I kept it around for longer? I can actually do things like inhibit the enzymes and keep those levels up for longer, right? So I can give a drug that actually blocks the effects of monoamine oxidase, or I can give a drug that blocks COMT, and that will then increase levels of dopamine and try to restore normal transmission again, right? So you can have someone who has relatively no dopamine, and I can give them a replacement, or I can just try to keep the dopamine that's around for longer and try to make sure that's still working effectively. Okay. So again, when we talk about Parkinson's in the neuro section later on in I think Pharm 2 probably, we'll talk extensively about different ways we can manage dopamine in those patients. Do you have a question or another comment? No? All right. Sounds good. So anyway, so we mentioned this is important for movement, especially in places like this nigrostriatal pathway, but it's also really important in this mesocortical pathway. We call this the reward pathway. So if you guys, maybe the upperclassmen may have mentioned this, but if you ever hear about the dopamine squirts, that is a Wood original term they found pretty funny. But this is that reward pathway. When you have something pleasurable that happens to you, so say for instance, you have a juicy hamburger, or you do a bump of cocaine, or you have sex, or whatever, the reward pathway is going to be stimulated there. I don't recommend the cocaine one. The other two are okay. You're going to find that these reward pathways are going to be stimulated. You're going to be releasing dopamine, and it says, hey, this was a pleasurable experience. This is really good. I want this to happen again. And that way you're going to have these reward pathways are going to be set into place, right? That's how you can have basically the basis for addiction as this occurs. So again, if I do a bunch of heroin, you're going to have that dopamine pathway is going to be stimulated just like it would be if I was eating a big hamburger, right? It's going to be a lot more intense with heroin, but the same thing happens there. So again, when you start to have less of that stimulus around, so you have someone who says, is doing heroin pretty regularly, and all of a sudden they go off of it or they run out of it, that reward pathway says, hey, we really need to get this stuff going again. We need to get some more dopamine here. If we don't have that, guess what? we're going to go into withdrawals. And so that's basically the basis for addiction there. And actually, a lot of the new treatments we have for things for addiction, like alcohol addiction, opioid addiction, binge eating addiction, things like that, are actually targeting dopamine. They want to reset this reward pathway to try to make it so that you don't have that intense craving to have whatever it was that you're potentially addicted to, right? Yes, ma'am.
Sorry to like backtrack, but if you're giving someone medication to stop those two enzymes, aren't you gonna mess up their acetylcholine?
Which enzyme?
Trying to control the dopamine, then wouldn't it?
Okay, so these enzymes here.
Yeah.
So that these two enzymes are not specific for. They have no effect on acetylcholine, right? So they're really only going to be.
Sorry, norepinephrine.
Norepinephrine. Yes, that is absolutely true. You can actually see that. So what would you imagine would be a side effect? Say, what do you think a patient's blood pressure would do if I gave them something to block the effects of, say, monoamine oxidase? Should decrease or increase? So I'm trying to do, say I have a patient who's got low amounts of dopamine and they're having problems initiating movement, the shuffling gait, this pill rolling you see with Parkinson's. And I give them a drug to try to block the effects of monoamine oxidase. So I increase levels of dopamine, they can get around better, but now they have more norepinephrine. And so what do you think their blood pressure does? It's going to increase, right? So hypertension could be a potential side effect there, right? Now, sometimes what we can do is we can get really specific for different isoenzymes, or basically different types of versions of the same enzyme, essentially. And so in this case here, there's one called monoamine oxidase B. There's an A and a B. If we target the B one, that is much more specific for dopamine within the CNS, and you don't really see those more global effects like things like hypertension, right? Again, outside of our scope for this purpose here, but just know that you can get more specific, and then typically the more specific you are, the less of those kind of other ancillary sort of side effects you can see with that. But that is absolutely a concern you can see with that. And again, I'll talk about serotonin in just a second, but one of the things you can find with that is if you have some issues with monoamine oxidase inhibition. So I'll talk about that in a minute.
So how much and for how long are you able to produce dopamine in that? I mean, I just read like random articles.
Mm-hmm.
For example, with like Facebook depression and people who are on like social media in the mornings, apparently they secrete that like extensive amount of dopamine in the morning, so that's why it leads to things like the whole Facebook depression. That's why they say don't go on it in the morning because you're releasing dopamine. That's why. Just yeah.
I'm not familiar.
Like a tangent.
Yeah, no, that's interesting. So questions regarding depression associated with like social media utilization, maybe getting all your dopamine out in the morning. I don't know. I feel like more depressed when I'm just looking at the Facebook, but like, look at all my friends, they have a way cooler life than I do. Like that's what I would imagine. But yeah, maybe just getting that hit of like, yeah, I'm getting to see what my crazy aunt posted up about Trump today, and just all kinds of random stuff. Yeah, I don't know. I'm not really familiar with that process. But yes, you can run out of neurotransmitters. So again, it gets back to your question of like if you deplete dopamine levels early, if maybe you have sort of a reactionary depression that happens later on, we can actually see that. So the way I see that more frequently clinically is if you have, say, someone goes on, say, a major bender of like, say, methamphetamine, right? So one of the things you'll see with methamphetamines, and again, this is important for you guys clinically because what disease state do we treat with amphetamines? ADHD, right? So again, anyone's taking Adderall or Concert or anything like that, you're basically taking speed, right? So it's all in the same chemical family. So what you actually end up finding is that patients that are going on these like major meth benders or cocaine or something like that, one of the effects those drugs have is they actually will block reuptake of a lot of these neurotransmitters. So they'll block the reuptake of things like dopamine, they'll block reuptake of things like norepinephrine. And so what that'll actually do is increase the levels of neurotransmitters in the synapse, and that's what has that extra stimulatory sort of effect, right? However, if I keep blocking the reuptake and all that neurotransmitter just sitting right here in the synapse here, what do you think is going to happen to all that neurotransmitter? If it doesn't get recycled back into the neurons just sitting here, we have enzymes, right? Enzymes are going to sit there and break it down, right? So you have things like catecholaminomethyltransferase and monoamine oxidase would then break down those neurotransmitters, and then it takes time to replenish those neurotransmitters. It takes time to get those built back up. So if you deplete that, they can have this sort of reactionary depression, this really big sort of like sedated, sort of kind of wash out sort of effect that occurs when they kind of run out of neurotransmitters. That's something you can see clinically if someone goes on a major bender over the weekend or something, right? So that's where I would see it clinically, but maybe you would see it with other cases too, like if you have Facebook-related depression. But that's why I stay off Facebook, so I don't get depressed from it. But yeah, so again, we were talking about things like reuptake transporters. This is an example of one right here. We have dopamine reuptake. Again, if I were to block that reuptake, levels would increase here in the synapse, and it would be, again, more stimulatory. So again, that makes sense why you would see, you know, increased addiction with things like amphetamines and cocaine, because they're actually blocking the reuptake of dopamine. More if they're in the synapse, more of that reward pathway is going to be stimulated, and you're going to get that need to have that around all the time. And once you lose that, that's when you're going to have, you know, that big desire and that craving sort of kick in there. Okay. Now keep in mind with dopamine, there's a couple of varieties of receptors, but again, some of these can be stimulatory, some of these can be inhibitory. You know, so again, and a lot of these ones here are going to be actually working through secondary messenger pathways, and again, primarily this one's going to be working through adenylyl cyclase. Again, I'm probably not going to get as granular to ask you on a test specifically. Hey, is D1 or D2 inhibitory or excitatory? We'll talk about those later when we get to specific examples like in pharm. But just know there are dopamine receptors. Know that some of them are going to be excitatory, some are inhibitory, and depending on which one you're targeting, can have very different effects on the body, right? So again, if I want to make sure that I'm treating my patient with Parkinson's, I want to make sure that I'm stimulating the right ones to get their movement issues, you know, resolved, right? And up next is serotonin. You'll oftentimes see this abbreviated as 5-HT. Does anyone know what that means? 5-hydroxytryptamine. So it's basically another name for it. It's a chemical name for serotonin. So if you ever see 5-HT, that's just what we're referring to. This is actually made from tryptophan. Anyone know where you find tryptophan? Turkey, right? That's why when you eat a big turkey dinner, say at Thanksgiving, what happens afterwards? You get sleepy. I also would postulate that it's because you consume 3,000 calories of food, and now all the insulin rushing your system is making you a little sedate as well. I would say it's probably more likely to do with it, but maybe the tryptophan's helping a little bit, right? So again, we'll find that serotonin typically is going to have more of an inhibitory effect on wakefulness. We'll see that in the next section coming up a little bit later. Anyway, so the big thing here is it's also going to be metabolized by monoamine oxidase. Okay, so again, when you think serotonin, what do you think of its like main functions? Happiness, right? So again, we consider this like the happy neurotransmitter, right? Because we see that when you modify, if you modify levels of serotonin, you can have good treatments for things like depression and anxiety. Again, we'll talk about this more extensively in the neuro section or the behavioral health section and pharm later on. But this is the main thing we're targeting. And actually, the first drugs that we had were actually monoamine oxidase inhibitors. It would work to increase levels of serotonin. The patient would feel better. They had their symptoms of anxiety and depression fixed. However, this was not very specific. So just like we were kind of alluding to earlier, if I inhibit breakdown of serotonin through monoamine oxidase, what else is that inhibiting the breakdown of? Norepinephrine and dopamine. So that means we have these patients who have these higher levels of that too. So again, if they had hypertension already, that's going to make that worse. You know, if they had a history of arrhythmias, maybe that could potentially worsen that. And also the thing was, remember what precursor did we use to make norepinephrine and dopamine? Tyramine. So again, tyramine was the thing we can get. And again, so you'd have these issues where patients would be taking a monoamine oxidase inhibitor for depression. You had to tell them, don't drink any, you know, nice red wines, don't drink any, or don't eat any aged cheeses or, you know, like aged meats and things like that. So don't go to any fancy parties and eat anything there, because they would have an increase in production of norepinephrine, in addition to a decrease in the breakdown of it, and thus you could see some issues here. You can see a lot of you know, negative effects like tachycardia, you know, overstimulation of the sympathetic nervous system, etc. Yes, ma'am.
So I was reading that some patients are being treated with MDMA.
Mm-hmm.
How is that related with serotonin?
Okay, so you're asking about MDMA being used for treatment of depression. So what's another name for MDMA? Ecstasy, otherwise known as Molly. Some of you guys are answering that a little too quickly. We'll discuss that later. But right, yeah. So we're talking about ecstasy. So that's actually kind of interesting because so ecstasy is a type of amphetamine. Does anyone know what MDMA actually stands for? It stands for methylene dioxymethamphetamine. So again, they got methamphetamine right there in the name. So chemically, it's very similar to a lot of the other amphetamines you run into. What's interesting about MDMA is the fact that it actually has some effects to block reuptake of serotonin. You normally don't see that with things like you know, meth or other amphetamines. The kind of unique thing with MDMA is why when they're blocking all that reuptake, they have all this extra serotonin. One of the effects you're going to see with MDMA, and again, this is what I see clinically, or maybe what has been reported, not necessarily experienced personally, is that they get very kind of touchy-feely. They call it like an enactogen, where basically like you don't necessarily, it's not like a sexual sort of like contact you're going for, but like you just want to hug people. You're just really happy, kind of happy-go-lucky type. I know it sounds weird, but that's what happens. But anyway, so the feeling is, well, if we can maybe modify these levels of serotonin with things like MDMA, perhaps that can help with treatment of depression. So that is why that one in particular is being looked at, due to the fact that it's more specific for serotonin. So hopefully that answers your question a little bit. Yes, ma'am. So so again, it all goes back to the dose, right? So again, if I use a little bit, maybe I'll get just enough of an effect on depression that it works. However, if I use a lot of it, actually you can run into cases where they can actually burn out these serotonergic neurons, and they can actually have what we call anhedonia. Anyone ever heard of that name before? It's gonna be the name of my black metal band one day, but it's basically like you have lack of enjoyment in things, right? So it's a pretty good name, right? But yeah, so basically they can deplete those neurons, and again, in some cases it could just be temporary, where it takes time to build that serotonin back up, but in some cases they just burn them out. They just do way too much, and so you can find they just don't find joy in anything anymore. They just can't really get really happy about much, and so it can be a problem they run into. Again, not often, but it's been reported, right? So, anyway, as you can tell, I love talking about illicit drugs. It's one of my favorite things to delve into. Anyway. Which is ironic because I did zero drugs growing up because I was just a big nerdy white kid. So I was like, ooh, tobacco, thank you. Like, yeah, caffeine was my drug of choice. Anyway. All right, so looking at use of serotonin, so again, mood altering definitely has a role in anxiety. What's actually interesting is when you look at things like drugs to treat depression, they actually take a long time to kick in, like 6 weeks before they really actually work to treat depression, or the symptoms of depression and anxiety. And so again, it's not just levels of serotonin that's there, but we do know that by modifying this, there are changes that occur that will help with moods. That's one big place we're going to see that. There's a lot of different types of serotonin receptors that are out there, though, right? So there's over 14 known right now, and there's a lot of different subtypes. So you can see here some examples like 5-HT3, you can see 5-HT2A and 2C, 1A. We'll get into those more specifically as we get into drugs that affect them, but there's a wide variety of effects you can see with this. So for instance, if I block 5-HT3 receptors, I can have pretty good effects on treatment of nausea and vomiting. So has anyone ever heard of Zofran before? Or ondansetron? That is a drug that blocks those serotonin receptors, and thus you have an alleviation of nausea and vomiting. So it's a great drug. It's like liquid gold in the ER. You can also have things like cerebral blood flow being affected. So there's 1B and 1D receptors that actually will affect cerebral blood flow. So again, if you imagine if you have too much blood flow going to the brain, you have all this pressure building up, what do you think that may manifest as? Headache, or more specifically, migraine. Yeah, so actually a big treatment for migraines is actually by activating those receptors. You can actually squeeze down and actually decrease that pressure in the cerebral vessels and actually have alleviation of pain, right? So again, there's lots of different things we can do with serotonin, a wide variety of things, and we'll go over all of those as we get into them in Pharm. But just know, again, there's a lot of uses for here, including mood, nausea, vomiting, blood flow, all sorts of things. All right, so any questions on the first half? One thing I forgot to mention, for the next section, part 3 of the CNS, I re-uploaded that, so I request that you download that when we get to it from Canvas. I had to make a few corrections, once again proving my fallibility. Anywho, so any questions from the first half? You guys feel okay on neurotransmitters? Hopefully by at least relating it back to illicit substances, maybe it'll help kind of train your memory a little bit better, because those are kind of fun to talk about, and so many of them are affecting our neurotransmitters. But anywho, continuing on, another one that we deal with a lot with certain substances is going to be GABA, or gamma aminobutyric acid. Okay, so GABA, I've kind of alluded to it before. We've talked about it briefly. Anyone know what the general function of GABA is? Slows down everything, right? It's going to be the brakes on the system, right? So, I think of glutamate. We'll talk about that in a second. As kind of being the gas on the car, the gas pedal. This is going to be the brakes. It's going to slow everything down, and you're going to see why that is in the case of the receptors here in just a few minutes. But basically, you're going to find that GABA is being made from glutamate. And so again, you're going to find this kind of balance between glutamate being excitatory and GABA being inhibitory. But to get GABA, you have to have glutamate to begin with. And it actually requires vitamin B6. So one of the things you can actually run into if you run out of B6 is you can actually have patients who cannot produce enough GABA. And what do you think could happen if I didn't have enough inhibitory neurotransmitter? You're way too excited. What happens when your brain gets way too excited? Seizures, right? So again, seizures can be one of the big things you can see with that. If you have a B6 deficiency, it's severe enough, deplete that GABA, and then you can run into issues like this, right? The metabolism is going to occur through GABA transaminase. And so again, this is one of those things where I could ask a question, hey, say for instance I have deficiency in the activity of GABA transaminase, what could occur? I may have things like sedation, seizures, tachycardia, things like that. You'd be able to intuit, okay, well I know if I have deficiencies of the enzyme, I would have too much GABA around, and it would be inhibitory overall. So the main functions you're going to find are going to be that it's generally inhibitory, as I mentioned, and is generally going to hyperpolarize the postsynaptic neurons, okay? And this makes sense because if you look here, here's a GABA A receptor and here's a GABA B receptor. Again, they have different functions in what they're going to do, but predominantly they're going to be inhibitory. And so you can see here the GABA A channel is the one we deal with most often in medicine. You're going to find that as you open this up, what do you notice flowing through? Chloride, right? So we're letting, it's going to be one of those anion transporters here. We're actually going to be allowing chloride to flow in. And what do you think that does to the electric potential for that neuron? Yeah, it's going to make it more difficult to have an action potential. It's going to inhibit it, make sure it does not fire. So again, when I'm treating a patient who's having a seizure, and I know they're having too many neurons firing all at once, well, what do you think I give them to fix this issue? I can give them more GABA, but we don't really have any ways to do that clinically. There are some drugs that can modify levels of GABA that can actually be used to help prevent seizures from occurring. But actually, one thing I can actually do is I can give something that makes the GABA that I have work better. And so there's when I talk about benzodiazepines or benzos, that's what I'm referring to. Is basically something that helps the GABA that you have work better, and it'll help to open up more of those chloride channels and hyperpolarize all those neurons. And that way, it's going to go ahead and make sure that it can shut down all those rapidly firing neurons, and the patient can hopefully go to sleep essentially, right? And then kind of fix that seizure issue. But again, GABA transaminase is the main way we're going to be metabolizing that. I mentioned GABA A channel, GABA B. Notice GABA B here. What kind of receptor is that? Kind of their fun ways. Yeah, showing a G protein, kind of those transmembrane segments there. It's not important to know specifically. Just know there's different varieties of receptors, and GABA A and B are the main ones we're going to deal with most often here. Okay. Again, alcohol is another big one that affects GABA as well. It's going to help to enhance GABA, make it work better. So again, that's why you can see sedative effects with alcohol, because it helps to make that work more effectively. Glutamate, on the other hand, we mentioned is going to be mainly excitatory. It's actually produced from glutamine. You can actually see on the previous slide, you can actually see how the glutamate will actually be converted over into GABA. And one of the big problems you run into is if I have not enough GABA being produced, say you have that B6 deficiency, this is where you run into issues, because glutamate is going to be predominantly excitatory. Now, the enzyme that metabolizes this is called glutamic acid decarboxylase, or GAD. You might see that. That's what's going to metabolize glutamate. And I mentioned it's going to be primarily excitatory. And actually what can happen is a glutamate can be a pretty dangerous neurotransmitter if you have too much activity of it. And in fact, we can have what we call excitotoxicity, where if the neurons are firing too much or they're too overstimulated, that can eventually cause permanent damage to the neurons, where it can either cause it to die off completely or may kind of worsen its function over time. This is one of the reasons why we think patients develop things like Alzheimer's disease, right? So Alzheimer's, what happens for a patient? Yeah, so they're starting to have degeneration, a lot of neurons. Actually, they're acetylcholine neurons. We're going to find that's really important for memory. But the main manifestations of Alzheimer's is impaired memory, right? So anyone seen the movie Coco? It's on Netflix. Cried like a baby right at the end of it. It was so sad. Because my grandparents have pretty significant Alzheimer's, and so you go watch that movie, you'll probably be. I told my brother to watch it, and he's like, I didn't think anything of it until I got to the very end, and then all of a sudden I was weeping openly on the couch. And I was like, see, I told you. But anywho. But yeah, so Alzheimer's, that's a big thing, is with memory, and that's actually and one of the theories of why people develop Alzheimer's is due to this glutamate excitotoxicity that can occur here. So that's one of the main things we may do to actually help prevent the activity of glutamate, to help try to preserve those neurons as long as we can. So one other way we can modify the system here. Now, there's several different types of glutamate receptors here. We're going to have things like NMDA receptors, other ones like AMPA receptors, and there's also what we call metabotropic receptors. Basically, they're just going to be modifying the kind of metabolisms occurring within the neuron itself. The main one that I am most concerned with, at least from a emergency medicine standpoint, is this NMDA receptor. Anyone ever heard of an NMDA receptor before? Basically, what I can do is I can block the effects of glutamate. I can block this receptor here, and can actually can develop what we call a dissociative anesthesia. So anyone ever heard of ketamine before? Special K? That's a drug we use very frequently in the peds ER. And again, what's the kind of ketamine kind of notorious for? It's used as a date rape drug for a long time, right? It's a veterinary anesthetic too. You can use it in animals as well. But one of the nice things about ketamine is it basically causes this dissociative anesthesia where the signals from the body basically are not making up to the brain. So the patient, we can do things like, reduce fractures. We can, put joints back into place and all kinds of things. When this drug is on board, the patient never really kind of experiences any of it. Basically, you're kind of giving them an out-of-body experience. It's a very cool kind of drug in that standpoint. So again, you think, oh, I'm giving a bunch of little kids ketamine. Again, it's professionally, not recreationally. But yeah, so again, this is one of the big ways. And actually, what you're going to find is that ketamine is a big drug being looked at for its use for treatment of like depression, PTSD. So you're going to see a lot of that coming forward in future years. And a lot of it is to do with blocking that NMDA receptor by blocking glutamate, essentially. So one thing you might see in the future. Okay, some other neurotransmitters we're going to see occasionally, things like glycine. Glycine is actually really important for spinal cord function, and actually there's a poison called strychnine that when you inhibit that actually causes way too much excitatory effects at the muscle. So typically glycine is inhibitory, and actually if you have someone who's blocking those effects of glycine, you can actually have like severe contraction of the muscles. They get very rigid, not able to relax the muscles. You can see things like rhabdomyolysis develop, can be pretty bad. So glycine is one you'll see occasionally. Histamine, anyone ever taken like Benadryl before or familiar with Benadryl? What is the usual effect you're going to see with that drug? You get sleepy, and a lot of it has to do with the histamine effects, also some acetylcholine effects as well. But the histamine itself, when you block those effects, usually can cause, if you have stimulation of those receptors, it usually causes arousal, but if you block it, it can actually cause some sedation for most patients. Some other effects like body temperature effects and vascular dynamics. Predominantly, though, here we're talking about the H1 receptors. Remember where we saw H2 receptors? Right, working with histamine, but where in the body do we find those? In the stomach, yeah, the GI tract, right? So we're going to find that in the stomach that is going to be stimulating release of HCl, right? So again, if I can block H2 receptors. So again, when you're talking about histamine blockers, there's H1 blockers and H2 blockers, and it's important to keep those in mind, because if I give someone Zantac for sleep, they're going to not really have any effect because it's blocking the wrong receptors, right? They won't have any GERD, but they're not going to really go to sleep from that drug. But other things like nitric oxide. We see nitric oxide being really useful for things like smooth muscle relaxation, like in vascular smooth muscle, but it also can be released by the nerves. It's thought to help with some facets of behavior and long-term memory, so that could be one thing you'll see. And then everyone's favorite, cannabinoid receptors. You have CB1, CB2. CB1's the main one you're going to see as far as causing like any kind of psychedelic sort of effects or any kind of mood-altering effects. And where do we find cannabinoids normally? The devil, yes. The devil's grass, yes, indeed. Marijuana is where you find, yeah. So THC is actually a compound, because again we get the name usually from where whatever we find is the first thing that interacts with it. So just like we have nicotinic receptors from nicotine, we have cannabinoid receptors from cannabis, basically. So marijuana has THC in it, and this is what's interacting with those CB1 receptors to cause mood altering effects and euphoria and all that kind of good stuff, right? Yeah, there's also CB2 receptors. Those probably have something to do with like metabolism in the body, but it's not as clinically relevant from the CNS sort of standpoint. But however, what are some medical uses for marijuana that we can get out of it, right? So let's say we take the devil out of it. What can we use those cannabinoid receptors for? Glaucoma, right? Can actually cause decreases in intraocular pressure. That's one way. One thing you can do. What else? Yeah, so actually it's kind of interesting. So there's two main components in most strains of marijuana. There's THC, which everyone's pretty familiar with. There's also one called CBD, or cannabidiol. And actually cannabidiol is thought to actually have some good potent anti-seizure effects. And before Morgan & Morgan got medical marijuana legalized in Florida, or at least he helped, you saw that we had one strain of marijuana that was actually available for seizure treatment. And again, it's like really refractory seizures, and it was called Charlotte's Web. And that had a high amount of cannabidiol. We actually could grow the cannabis that way. It had almost negligible levels of THC, but had high levels of CBD, or cannabidiol. And that actually had good anti-seizure sort of effects. So that's one way we can use it from a CNS sort of perspective. Yes, ma'am. Okay, yeah, so that's not one I'm familiar with as being used commonly, but yeah, if it helps with muscle spasms, then go for it. The nice thing about the law, the way it was written, at least here in Florida, is that it gives you a list of like things that we would use it for commonly, or at least has been reported, and they say, well, and whatever else the provider thinks it might help with, right? So it kind of gives you like a clause that kind of say, okay, well, use it for other stuff too, potentially, if you feel like it's going to have some benefits. The other big thing you're going to see, and typically when people, say you're smoking marijuana or using marijuana, what does it do to your appetite? usually increases, get the munchies, right? We can use that for patients who maybe are having wasting disorders, or patients who are having, say for instance, like cancer patients who have, receiving chemotherapy, your GI tract is being affected pretty significantly. You're not really hungry, you're not eating, and then your nutrition goes downhill. We can give them things that will affect cannabinoid receptors to try to stimulate that appetite and help them put on some weight. Other things, nausea and vomiting can also be treated with cannabidiol things that affect the cannabinoid receptors. So this is something you may see as well. Yes, ma'am.
Should we know which one would be like THC versus CBD?
No, I'm not going to ask you that specifically, but I may say like, hey, what would be something that interacts with the cannabinoid receptor, right? I may have like acetylcholine, norepi, dopamine, or THC, and you'd be like, okay, well obviously I'd put the full name on there, so delta-9 tetrahydrocannabinol, if you're curious. Yeah, anyone ever heard of hyperemesis syndrome associated with marijuana? Actually, it's really, really cool. So it's a rare thing that you can see, but you see with patients who are smoking a lot of marijuana, or I guess they're ingesting it, but they're using a lot of it, and basically they get this severe hyperemesis that occurs there. And so there's some good case reports where you have these patients that are coming back to the ER over and over again for this nausea vomit. They cannot figure out what in the heck is causing it, because they have relatively younger, healthy individuals, and they just can't stop vomiting. The only thing that actually helps it, anyone know what the thing that helps it is? Do you know? Actually, smoke more marijuana? Actually, no. Actually, hot water actually helps it. So yeah, so these hot showers, these patients would like end up running through like all the hot water in their house, and they're like, it'd be one of the complaints you'd see is like people living in the house with them say there's no hot water anymore, because they would just stay in the shower, use up all the hot water, and it helped to resolve the nausea and vomiting. And so the only thing you can do to fix that is basically to cessation. So give them hot showers when they need it, but then also have them stop smoking so much marijuana, and then that typically goes away. So that's another kind of rare thing you may see occasionally. If you have a patient who keeps presenting for nausea, vomiting, you're like, what? There's no obvious cause for this. They're really resistant to everything else, and then you have this history of like, oh, they take a lot of hot showers. Okay, that's probably what it's related to. Because are patients usually forthright with telling you when they smoke marijuana? No, not usually.
It's actually not all that rare. We would see.
Oh, you saw it frequently?
We would see a couple cases a week.
Really?
Yeah.
Where were you working? There you go. People at the beach and.
Right.
Interesting, yeah. Okay, and I just know it was like kind of first reported a couple of years ago, but I guess more common. It's probably underreported for a long time and more common than we actually thought.
I've seen it a lot, but I'm a little bit confused on like how you would treat something like that, because if they experience symptoms by like not smoking, then like how would you treat them?
You have to kind of like gently wean them off of it, because again, if you like say for instance they're coming in, they're dehydrated, you brought them into the hospital, I can't give them marijuana there. I mean, there's an actual prescription product that actually interacts with the cannabinoid receptors. It's called Marinol. We use occasionally for like cancer patients and stuff, but I can't like give them a joint and have them light up in the middle of the ICU or something, right? Because then all the patients are going to do it, and we don't want to do that. But yeah, so basically, you try to give them supportive care, to give them fluids, you give them antiemetics, and again, a lot of times those aren't going to work all that too well. Let them take their hot showers, and then kind of gently titrate them off the marijuana, and that would generally resolve. It's not fun for them, there's not like a quick fix where it's just going to go away. It takes time to get them used to not having all that marijuana around, all that THC. Yes, sir. It has a kind of cyclic vomiting associated with it, so that would be probably another name for it. So anyway, so this list, not all inclusive. Again, these are just ones we're going to commonly run into from a medical care sort of standpoint. Again, we're going to have drugs that will try to increase activity to neurotransmitters. We're going to have things that try to decrease the activity. Disease states are going to increase or decrease. And so again, important to know that, okay, well, if I modify this, what are the downstream effects? What should I expect to see as a result of that, right? So if I increase norepinephrine levels, what should I expect to see? If I decrease acetylcholine levels, what should I expect to see, et cetera? Okay, make sense? So let's talk about the action potential again briefly here. So, normally we said our neurons are sitting at a positive potential or negative. Usually negative, right? So usually about negative 70 or so it's going to be sitting at. And obviously we need to make it to a certain threshold before we can actually have the action potential occur here. Now again, remember what's the main ion causing the actual action potential to occur? Sodium, right? Sodium influx is going to be happening here. How do we repolarize a cell? You let potassium out. Remember, because again, salt rat bananas, our neurons are no exception to that. High potassium levels in the cell. So when you're having repolarization, the sodium channels will close, and then you're going to find that you're going to have potassium leaving the cell that's going to have to repolarize it. Okay, so depolarization is just where the potential is going to be increasing. Repolarization there, returning the resting potential, and then most cells are going to have a hyperpolarization period where you're kind of going below what the normal is. And again, that's just kind of a little bit of an overshoot. But what gets you back to the resting membrane potential? Sodium potassium pump, right? It's going to come back again, working to make sure we're keeping it at that negative 70 roughly. Again, sending out 3 sodium against the concentration gradient, bringing in 2 potassium. Again, that's an active process. It's going to require ATP. And so one of the things you're going to see is that, yes, these neurons need a lot of energy. They need a lot of ATP to keep themselves functioning. And why, if you have someone who, say, has lack of blood flow to the brain for just even a few seconds, that's where you can see things like syncopal episodes occur because there's such an oxygen, necessary sort of organ there. So anyway, looking at the stimulus coming along, remember these are traveling along the neuron, right? And so we're going to have these synapses occur. They're going to have a transmission of action potential from one neuron to the other potentially, right? We talk about those electric sort of synapses there. There's also the chemical ones that can stimulate action potentials, but depending on what's happening, you're going to have the stimulus occur here. You're going to hit that threshold where sodium channels are going to open up. Sodium's going to flow in. You're going to have the sodium channels close, and then you're going to have potassium channels open up to allow potassium out. You're going to repolarize, and then sodium potassium pump's going to kick back in to get you back to resting potential. Okay, so what do you think we would do, or what could we do if we had someone who was having, say, abnormal firing of these neurons, and say they developed a seizure?
Lower the membrane.
So I could try to make the potential more negative, so I can do things like try to let more chloride flow in. That's one way. What else could I do? Well, how could I block this action potential from occurring in the first place? Block sodium channels, absolutely, yeah. So, yeah, a lot of the drugs we use for treatment of seizures, things like phenytoin, if you ever hear that, it's actually blocking sodium from coming into the cell. By blocking that, then you can actually prevent the action potential from occurring in the first place. It's another very potent anti-seizure medication is by blocking sodium channels. A lot of drugs will do that, and again, we'll cover that in the neuro section, but just when you're thinking about, okay, well, how can I modify this, and what kind of changes would I expect to see? So if I block sodium channels, no action potential occurs here. Now, on the other hand, what if I, say, block potassium channels here? What could happen? So you could actually delay the repolarization phase that can happen. Now, clinically, we don't do this as often, but you could imagine that instead of having this nice kind of steep sort of slope to the curve here, you can see it kind of take longer for that to occur. And then, remember, we talked about things like refractory periods. What's a refractory period? Yeah, a period where the neuron cannot be refired again because, again, it has to have time to reset. Well, maybe I can delay that refractory period or make it longer so that way another action potential cannot come along and cause another firing, right? So, again, you're going to see a lot of these types of things modified when we're dealing with things like epilepsy, when treating patients with different types of seizure disorders, okay? Yes, sir.
So you said a potassium blocker would be used to delay that refractory period?
It would lengthen it, essentially, right? It would kind of delay the repolarization phase, take longer, essentially. So that way it would cause the refractory period maybe to get longer, right? So again, clinically, it's not something we do as frequently, but certainly blocking sodium channels, if we can block the action potential from occurring in the first place, that's always going to be a good thing. And actually, it's kind of interesting because where else did we see the sodium influx? I can't think of a good way to actually ask the question, but think about the heart. Think about the heart. What causes those depolarizations to occur? What ion? Sodium influx, right? So again, a lot of the drugs you can actually see, phenytoin actually used to be used as an antiarrhythmic way back in the day before we realized it was a good seizure medication because it blocks the sodium channels. Again, you don't have to memorize that for this test, but just know that in the future when we talk about these things, there's a lot of bleed over of effects depending on what sort of channels it's actually working on, right? Okay. Again, that refractory period, there's an absolute and there's a relative. What's the difference between the two? Yeah, absolute is going to have no other action potential can occur no matter what, no matter how strong the stimulus comes along. The relative, you can't have a strong enough stimulus actually come in here. And that kind of makes sense if you look at this. If your sodium channels are still not reset, again, that's what caused the action potential in the first place, you're going to find you can't have another action potential occur. However, if the only thing that's happening here is the sodium channels are closed, but potassium's open, you could potentially have a strong enough signal come in. And that's how you're going to find that a lot of seizures can develop. And we'll talk about this in the next section of the class. But basically, you can have these kind of reentrant sort of circuits that develop, just like you can have arrhythmias in the heart. Same thing can happen here, especially if you have altered refractory periods, right? So just like if you have an MI, you have ischemia of the heart and you damage that tissue, that can lead to arrhythmias later because you're kind of altering the conduction of electricity in the heart. You can do the same thing to the brain. So if you have someone who has a stroke, you have someone who has hypoxic injury to the brain, they don't get oxygen for a long enough period of time, that tissue dies off. The same thing can happen. They can be more likely to have seizures afterwards due to the fact that they have this kind of altered refractory periods in their neurons, right? Make sense? So, okay. So let's look at the effects of having different synapses coming in, different neurons feeding into our one, because again, usually we're looking at kind of one-way transmission here, but let's see what can happen if you have other neurons that are coming along and affecting these neurons here, and as far as action potentials go. Now, normally we said a resting neuron would be around negative 70, negative 65, something like that, and that's going to be kind of throughout the entire neuron here. Now, you can have inhibitory effects and excitatory effects come in at different places on the neuron. And you're going to find different effects based on where it's going to be synapsing at, right? So imagine I have an excitatory neuron here. Say, for instance, I'm going to have glutamate. So glutamate neuron's going to be releasing glutamate here. It's going to be excitatory. You're going to see it would do things like increase sodium influx. That would then cause potentially an action potential to develop, and then it would travel down the axon, right, to whatever the next synapse is going to be, whatever effects it's going to have there, right? On the other hand, I could have an inhibitory sort of neuron here. So imagine I have a GABA neuron, a GABA releasing neuron. It's going to be releasing GABA here. It's going to open up chloride channels, and then that would hyperpolarize the neuron and then prevent an action potential from occurring. Okay, kind of makes sense so far. It gets a little more complicated than that, but basically what you're going to find is that depending on the number of synapses you have coming in, depending on the kind of the sum total effects of both inhibitory and excitatory neurons and synapses, you're going to find that you'll have a net effect of either firing off an action potential or not, as the case may be. And so, for instance, if you're looking here, imagine if you have, say, a difference between, say, 16 synapses firing onto one neuron versus 8 versus 4. What do you notice about the effects here? It's a lot stronger when you have all these excitatory neurons that are going to be stimulating it, okay? So again, in some cases, maybe just one neuron synapsing isn't enough to actually cause the action potential. Maybe you need a lot of them all doing it at the same time to actually cause the threshold to be met to actually have the action potential in the first place, okay? So there's a couple different ways this can happen. It's called summation. In one case, it's called spatial summation, where you can actually have multiple inputs coming in, where you have several synapses all firing at the same time on one particular neuron, or you could have sort of a temporal sort of effect here, where you have the same synapse firing multiple times, and sometimes a combination of the two. But again, the same effect is going to happen here. The more impulses it's going to be receiving, the more likely it is to have that action potential actually occur. Okay, and you're going to see it's going to be spreading along the dendrite, going to the cell body, and then traveling down the axon. You can see, depending on where I'm going to have its effect at, you're going to see some different effects here. I'll show you in just a second. Okay, so imagine here we have a neuron here, we have all the synapses that are coming in. The E is going to be excitatory and the I is going to be inhibitory here. And you kind of see the differences in potential here throughout the neuron depending on what kind of effects are happening here. One of the things to note is that the farther away from the cell body that the synapse is occurring, the lesser effect it's going to have. Basically, that amount of changes causing the potential is going to kind of die out over time. So even though you can have these excitatory synapses here, causing it to maybe get to like -10, so again, it's definitely raising it, getting it closer to that threshold. By the time you get to the cell body, it's going to be like back to -60. So it really didn't cause a whole lot of difference there. Okay. The other thing that can happen is you're going to find that if you had, say, some excitatory neurons synapsing here in this part of the dendrite, but then you had some inhibitory neurons firing here, what do you notice about that? It would shut down those excitatory impulses, basically kind of cutting it off before it could actually make it to the cell body to actually cause the action potential to occur there. Okay. Now, the strongest effect you could have from an inhibitory sort of standpoint is actually if I inhibit the axon itself, right? So instead of working at one of these dendrites, if I could just do it directly onto the axon, that's going to have a very strong inhibitory effect. You could have 1,000 different synapses here all saying, hey, fire off an action potential, but you have a couple of inhibitory neurons here, it's going to be a much stronger signal to say, hey, let's not fire anything at all, right? So you have a couple, like say, GABA neurons here letting chloride flow in, it'd be very, very strong inhibitory sort of signal there. Okay. So some other characteristics we can see with as far as like synaptic transmission goes, we see things like fatigue, right? So again, your neurons just can't fire off forever, just repeatedly. You're going to find that initially you're going to have these excitation discharges are pretty rapid initially, but then they can slow and they can kind of die out. This is important because when you have a patient who starts up with a seizure, do you want them to continue seizing? Typically no. So a lot of these tend to resolve on their own because as they're firing off all these action potentials, eventually they do tire out. They're going to fatigue and it's more difficult in order to actually have another action potential. So when that occurs, you can find that the seizures may self-resolve on their own, which is a good thing. This is a protective mechanism. So again, we mentioned having too much activation, too much excitation leads to that excitotoxicity. So this is a protective feature. The neurons do not want to wear themselves out. They don't want to over damage themselves. So this is what they do. They get fatigued and they prevent further action potentials from occurring there. Okay. Some of it could be related to things like, losing presynaptic vesicle content. So imagine those neurons that are synapsing lose, say, all their epinephrine, they just, or norepinephrine, I should say. They just use it all up. That could be one thing. You have inactivation of receptors that are going to be on the postsynaptic neuron, right? So if they say desensitize or downregulate or something, that could be one thing. Or if you have some abnormal concentrations of ions inside the cells, right? So again, the levels of potassium and sodium get off because they're firing so frequently they don't have time to reset. That could be another thing there, okay? Now looking at the effect of pH, typically you're going to find, and we talk about the seizure threshold for patients, patients who have seizure disorders, typically the lower the threshold, the more likely they are to seize. And so if I say something like raising the seizure threshold, that typically means I'm trying to make them more difficult to have a seizure. That's usually a good thing for those patients. So what you can actually find is that patients who become alkalotic, if they raise their serum pH, typically this is going to actually increase neuronal excitability and can lead to more seizures. On the flip side, though, if I have patients who are acidotic, that actually can raise the seizure threshold, make it more difficult to have a seizure, and so that actually decreases excitability to the point where I actually see coma that can develop here. But we actually have some seizure patients that are very difficult to treat with conventional, anti-epileptic medications. We'll actually give them something to make them a little more acidotic, right? Either give them a drug that can do that, or remember when I talked about ketogenic diets? What happens to the pH when it gives someone almost a zero carb sort of diet? They tend to start to develop ketones. These ketone bodies, they tend to get more acidotic. That, again, can also make it more difficult for them to have a seizure, which is why it's really important from my standpoint, being in the pharmacy. If I have a patient comes in with a ketogenic diet or on a ketogenic diet, I have to make sure that we're not giving them anything that has any sugar in it, because if that throws them off and gets them out of ketosis, their pH will raise back up, and then potentially we could cause a seizure. Typically not good for your patient, right? Other things you can see, hypoxia, very, very detrimental to the brain. We like to have lots of oxygen there. And so because of that excitability, it goes through a ton of oxygen. So even 3 to 7 seconds of cessation of blood flow. So say, for instance, someone has an arrhythmia. Say, for instance, they go into a short run of say VTAC or VFib. Say they have a congenital heart disease or something. That 3 to 7 seconds can lead to syncope. So oftentimes that's how we diagnose things like heart conditions. Is the patient has an unexplained syncopal episode. It's related back to that. So again, that's one of the big things you'll see there. Typically, the longer the brain goes without oxygen, typically worse for your patient. You see a lot of hypoxic damage being done there. A lot of those cells are going to die off. And you see lots of big problems there. And in fact, a lot of our kids we have over at Nemours who are the more difficult to treat seizure patients are typically had some sort of hypoxic injury as either when they were being born or at some point in their life. Say, for instance, they have, they had a near drowning event or something like that, something that caused significant hypoxia. They're the ones that typically have those kind of altered refractory periods, and they're much more likely to have seizures develop. So that's one of the things we see, unfortunately. And then obviously drug effects is the ones I like the most, right? Things like caffeine, theophylline, theobromine. Anyone know where you find theobromine? Actually in chocolate. That's why I don't want to give dogs chocolate. They can't process the theobromine, but these typically will cause increased excitability of the neurons, right? So most of you are probably hopped up on caffeine right now, right? Just to stay awake for this lecture. I understand, it's okay. These actually work through things like adenosine, and by antagonizing adenosine, it actually has kind of stimulatory effects. That's one thing you can see potentially. And then obviously sedatives, anesthetics, they typically are going to make depolarization more difficult. This is why we use sedatives for not only for sedation, but also for seizure treatment, because they're basically doing the same thing, all just a matter of the dose you're giving them, right? Okay, so any questions on that section? Yes, ma'am.
Sorry, just to clarify, so raising the seizure threshold is making it more difficult or easier?
Make it more difficult, because I'm raising the threshold, making it harder to get to that. Yeah. So when I say something lowers the seizure threshold, that also means that it's going to make it more easy for them to have a seizure, right? So if I were to give someone a sedative, so say I have a patient with epilepsy and I gave them, say, some alcohol, that would raise their seizure threshold. Saying seizure frequently is hard to say, I'll tell you this. But you're going to find that that would raise the threshold and make it more difficult for them to have that seizure there. Not that I recommend all your epileptic patients get drunk, but that is one thing that could be an effect there. But again, one of the big side effects of a lot of those medications you give them to treat their seizures is what? If I'm hyperpolarizing all those neurons, sedation is a big one, right? So again, you see patients, sedation is going to be one of the main side effects you're going to run into with a lot of those drugs. It's because I'm slowing down and making those action potentials harder to occur. It's going to lead to things like ataxia, nystagmus, sedation, all that good stuff, right? Anyway,